Good afternoon. This is Khurram Nasir, Chief of Cardiovascular Prevention and Wellness at Houston Methodist DeBakey. As part of our imaging symposium today, I would love to present some data on the role of coronary artery calcium testing in patients with chest pain. And although it has been one of the most heavily debated, I still think that this discourse is still alive and kicking. Before I start, I think just a few announcements. You can join by web, and you can, for submitting the questions, you can go to pollev.com, enter DeBakey, respond to the activity, and you can even send us questions by text DeBakey to 37607, text in, and then you can text in your messages. So moving forward, I'll present you a case as a part of the discussion in our clinic among two fellows, and this is kind of one of the most common discussions that happens in our clinics. 59-year-old male, dyslipidemia, hypertension well controlled, non-diabetic, presenting with both atypical and typical features of chest pains, and with a pretest probability of intermediate around 50 to 60%. The question really is, what's next? Of course, there are many options, but when we're talking about imaging modality choices, among the fellows who are having the conversation, the discussion really came out to whether we should pursue a functional test or an anatomical test via a CT angiogram. And as a part just to have some more provocative conversation, I just poked at the question, what's the likelihood that this test would be abnormal? And really, after a little silence, the answer I got, about 1/3 to 1/2 the chances are that anybody will have a functional test or a CT abnormal, about 1/3 to 1/2. But actually, when you look at the contemporary data from the PROMISE study, it's only about 1 in 10. For example, in this study of nearly 9,000 individuals who were randomized to a CTA strategy or a functional test strategy, about 11% in the CTA group and then about 12% in the functional test group had any significant findings suggesting obstructive disease or of any meaningful significance. Now, thinking about that, I think so. While you look at the pretest probability approach, which is ingrained by both the European and the US guidelines, which takes into account gender, age, and also your symptoms, I think so it's a very pragmatic approach. The rationale is, if you're low pretest probability, you can potentially avoid any downstream testing considering the favorable prognosis and any unintended consequences. However, even with the more calibrated and updated risk stratification strategies based on the pretest probability, you've seen that most of the time they're going to lead to an overestimate. So my whole response was that you can sit in another room without even reading this test and call them positive, negative, and you will be 90% accurate. Just highlighting that there is a need to do better. The second issue is that, in my belief, that the healthcare puck is really moving into the value-based medicine corner. That means that we truly have to maximize our yield. And in my humble opinion, in that care model, we just cannot afford majority of the advanced tests being normal, be it a CT angiogram or a stress myocardial perfusion imaging. And unfortunately, we have not yet been able to come up with a better mousetrap. And I think we need a much better gatekeeper mechanism that's not based on risk factor, but actual underlying disease. And in this context, we discussed about what would be the characteristics of a gatekeeper, especially in this low-risk chest pain patients. One of the key things is, of course, it has to be widely available. It has to make economic feasibility. It needs to be a straightforward evaluation where you don't need a specialized expertise to really use this, and more importantly, it needs to be accurate. That means you're truly highly sensitive and not missing out significant disease, and it's safe. When it's negative, it's ruling out the disease as well as possible. And of course, you're seeing I'm building on the notion, and when I suggested, well, the power of zero, which has been described in the past mostly for the asymptomatic individuals, the absence of calcium score, which has been shown to have a favorable prognosis and now well embedded within the guidelines. Can that be a solution? And my rationale was really based on almost 12 years ago when we published our seminal paper, which eventually led to the pathway of the power of zero getting incorporated into the cholesterol management guidelines. Was initially mainly focused on low-risk patients, where we clearly demonstrated based on the available literature about a high negative predictive value for obstructive disease. We also demonstrated that the likelihood of any ischemia is going to be minimal. And the more important thing, a very high favorable prognostic value, and with limited study even suggested that may rule out ACS by a negative predictive value of 99%, definitely holding significant promise. But it seems that, of course, we definitely lost the track over the last 10 years. And now speaking with the fellows, definitely they seem surprised and concerned and say, well, you know, the risk of coronary artery disease is not minimal. And this is not the first time I heard that. Of course, once in a while, I do get from case reports some of the studies showing significant obstructive disease on a CTA with a calcium score of 0. And the concern is profound and, of course, worthy to note. Of course, we also hear about papers coming out even suggesting that calcium scoring should be considered dead on arrival when we're thinking about chest pain. And the most common feedback is, I'm not comfortable with the calcium score of 0 in the chest pain patients. And these are genuine concerns that happen, and of course, not only based on this, but even apart from extensive studies that may suggest that calcium score of 0 may reliably exclude CAD, but even experts like Stefan Achenbach and many others have concerns, and typically so suggesting that even with the typical symptoms and the calcium score of 0, they would still proceed with some more advanced imaging. Now, in this context, I could definitely understand the nature of the discussion where it was happening with the fellows, and I say, okay, how do I proceed at fellows? So it was really a matrix moment for me, and this is a scene from my favorite movie, Matrix, where the rebel leader is pointing out to Neo and giving him option and saying, look, this is your last chance. If I give you take a blue pill, you wake up in your bed, you believe whatever you want to do, and you live in your fantasy. Where if you take the red pill, you remain in the wonderland. I'll show you how deep this rabbit hole is. And all I'm going to tell you and what you will know is the truth, nothing more, nothing less. So let's have a more candid conversation. So what's the main concern? What I was told about, well, you know, if I get a calcium score, it's not going to reliably exclude significant disease, and I need to be sure my patient doesn't have that. So where is the data? I think so we can look into the literature. One of the most profound, impactful study in this regard is the confirmed registry, led by, in this paper by Todd Villanis, about 10,000 symptomatic patients. And of course, if you look at this study specifically, about 16% patients had significant stenosis on CTA. Now that's kind of the real world evidence we see, but surprisingly, almost 1 in 2 of them had a calcium score of 0. Now, what about if you didn't proceed with the CTA in this? How would it rule out obstructive disease? Well, if you look at the data, it's about the sensitivity, negative predictive value. That means every time a test is negative, almost 97% of these individuals will have no stenosis of 50% and almost 99%. But mind you, this is the entire spectrum of the disease, including those at the high pretest value. And in my prior debate with Todd, he acknowledged that the negative predictive value is likely going to be better for the low-risk patients. Now, depending upon which side of the bed you woke up, either the glass is 97 to 99% full or 1 to 3% empty. But again, this is the real-world evidence. So, but what about in more controlled settings? So let's take you to the PROMISE study, which was initially truly designed to look at outcomes comparing those undergoing CT angiography versus the functional testing. However, the beauty of this study was that they also undertook the calcium scoring, and in a later publication in Circulation, Matt Bodoff and Udo Hoffman tried to identify how good is a calcium score of 0 in ruling out obstructive disease. And behold, what you found exactly what we have seen from the real world evidence in the confirm. Almost 99.5 to 98.5% negative predictive value. It's just hard to beat these numbers. But once you're absolutely sure that the risk of obstructive disease is almost non-existent, then the second concern comes, and fine, that's all right, it does rule out obstructive disease. But in the end, we are not talking only about the disease condition. I truly want to understand the prognosis, and in our view, a calcium score of 0 does not equate to a favorable prognosis in asymptomatic patients. Well, when you start diving deep into that, among one of the first studies in early 2010s was from Edward Holton and Marcio Betancourt with Ron Blankstein from this fantastic partners registry based on the CT. And what they found again, this is the third or fourth or fifth study suggesting that the rule out of a calcium score of 0 is almost close to 100%. Now, there were about 1.5% individuals with a calcium score of 0 who had obstructive disease, but clearly in a 2.5-year follow-up, as you can see here, that there was no event, no adverse clinical events, no MI, no procedure needed, no death. Pretty reassuring in a real-world registry data. But let me take you to the PROMISE study, which was an outcome-driven randomized clinical trial where if you look at the normal functional testing, the standard of care for majority of the country, which is pretty reassuring in 2.5 to 3 years follow-up, the cardiovascular death MI rates is about 1.3%, and all the way, including all-cause death MI, and even unstable angina of about 2%, which is almost less than 1% annual rate. And this is the basis of our class 1A recommendation for most of the functional testing. But how would a calcium score of 0 portend in that? I did ask the fellows to take a guess, and their thought was that the risk would be at least 50% to 100% higher. But in reality, actually, it's the reverse. If you look at a calcium score of 0 with a stable chest pain, the outcome is about 0.6% will have a cardiovascular death of an MI, as compared to 1.3% with the normal functional test, which we are all pretty comfortable sending them back home. So, and you don't have to trust me, and if you look at what Matt Bodoff and Udo Hoffman suggest, they also tend to agree now, based on the enough of evidence that they have seen in the PROMISE study, that it's time that we think about calcium testing as an initial test. And again, by the way, not as a diagnostic test, but more as a gatekeeper followed by a second test. And in their view, it also supports the use as the first approach as done in Crescent, and I'll show you later on in the next 10 to 15 minutes, that once you have a calcium score of 0 in a stable chest pain patient, there is no further need for additional tests. So I've clearly shown you the 99% predictive value ruling out obstructive disease. We have shown that it works in the randomized control settings, and we have shown the short-term events in the real world as well as the PROMISE study. But what about the long-term effect? Maybe you're missing some disease. Maybe that portends downstream significant events. So again, kudos to Ed Nichols, who worked with Taran Mittal and Adam Timmis and looked at 3,000 patients who had CT angiogram and calcium score. Again, almost 1/2 of them had a calcium score of 0. The question is, would they benefit from downstream CTA testing? And if you believe in the power of 0, you could rule out again and again and again, as shown in this study too, with a 99.5% negative predictive value. And they actually followed these individuals for 13 years. About 4% had some death. Now, take a guess, how many of individuals with a calcium score of 0 died from a coronary event? The answer is 0. So again, not only short term, but actually follow-ups up to 13 years. If your patient with stable chest pain has a calcium score of 0, which is seen in almost in 1 and 2, you can be reassured about their favorable prognosis for the next 13 years. And in fact, not only they suggest that a 0 calcium exclude obstructive disease, as we all know by 99 to 99.5%, they also question whether there is any need for further testing when the calcium score is 0. So this is really where we are in 2021, that in spite of the fact that we have significant evidence, still there are major concerns. And the major concern for me is that this information is not really disseminated via guidelines or via prospective pieces or educational material to our trainees who are still not aware of this evidence. Not only that, there is the third concern that really pauses us, that fine, there is no obstructive disease, but we're also interested in ischemic heart disease. What about ischemia? How good is a calcium score of 0 in ruling out ischemia? In our earlier study about 12 years ago, when the data was scanned and we looked at 8 studies, about 3,700 individual patients, about 7% presented with a calcium score of 0, who had a calcium score of 0 but had ischemia. Now, we didn't have really the information whether it was mild, it was moderate or severe, or anything that was meaningful. And in fact, almost about 8 years after, in 2016, Alan Rosinski led another study which had now more than 7,000 patients, truly confirmed our finding about 6.6% individuals. So that's true, about 6% individuals with a calcium score of 0 may have some ischemia. Now, the notion is some of the studies have suggested that if you use the coronary artery calcium score data, presence, absence, higher burden, a lot of time there is a refinement of the decision whether the test was positive, equivocal, or negative. So, and that has been shown in the past, and I think so, in my honest opinion, most of them are likely going to be artifacts. But in essence, the real issue is, does it really matter? If you have minimal ischemia or maybe an artifact-based ischemia that you're calling it ischemia and a calcium score of 0. So in this classic study that I want to refer you to, led by Alan Rosinski and Dan Berman many years ago, where that caught my eye, and especially if you look at the calcium score of 0, at least in that era, about 1.2% had some ischemia in the presence of it when you had no coronary artery calcium. But more importantly, if you look at downstream events, and only about 1% actually underwent a cath. There was no revascularization in less than 2 months, no delayed revascularization. In a follow-up that was almost 32 months, there was no MI or coronary death. Now, this is a small study, about 252 patients with a calcium score of 0 with a shorter follow-up, but just recently, Mohammed Madan's group, with whom I work very closely, and Alismak Engbers, came out about 5,000 individuals. Almost exclusively, all of them were intermediate risk. And for almost 4.5 years follow-up, what they found that almost about 7% had some MACE. And yes, about 6% individuals had a calcium score of 0, but all of those were classified as exclusively mild. So take a guess, in about 5 years events, in individuals who had a calcium score of 0, who also underwent a stress myocardial perfusion imaging, and very few of them having a positive stress test with mild ischemia, what would be their events? Do you think they're going to be at a higher risk? Actually, not at all. If you look at the data, the risk of, in a 5-year event rate, annualized event rate, is about 0.61% if you have a normal SPECT versus 0.41%, which again, not statistically significant, but again, showing that in the right direction. Whereas once you start having disease with the minimal atherosclerosis with a calcium score of 1 to 99, 100 moderate to severe, about greater than 100, and severe greater than 400, at each level an abnormal SPECT that indicates true ischemia in the presence of the disease is associated with a worse prognosis. So clearly, the emerging data is pointing us into the direction that there is no increased risk with an ischemia when a calcium score of 0. So the whole idea is, in a stable patients, not only you're ruling out disease, you have a short to an increased term of favorable prognosis. The risk of ischemia is almost minimal. Most of them are mild and no increased risk with a calcium score of 0. And then again, when these authors were asked to present their views, their whole idea is that when you're performing SPECT myocardial perfusion imaging with 0 calcium, you should be aware of an abnormal MI results are more likely to result from false positive than from true perfusion abnormalities. And in fact, they advocate that the addition, if you consider adding or considering doing a SPECT myocardial perfusion imaging with a calcium score of 0, it truly is result in an unjust invasive imaging with additional cost and risk of complications. So they share my sentiments that SPECT myocardial perfusion may not be useful with a calcium score of 0. And in the end, I feel I've learned the most from the gurus of nuclear cardiology, Alan Rosansky and Dan Berman, not only that, but imaging. And who am I to argue with them when they strongly advocate that there is a very low likelihood of atherosclerosis and myocardial ischemia in presence of a calcium score of 0, and referred those patients away from advanced imaging. But at the same time, not only that the calcium testing helps identify those who may not need further testing, actually you can see that with the presence of atherosclerosis and even in absence of disease, if you look at the guidelines and a lot of work that's done by Sumin Chang and John Memarian and Faisal Nabi at our institution have clearly showed that it adds significant value. So this combination of testing and the gatekeeper role is very critical, not only in avoiding unneeded tests, but at the same time supplementing together with advanced imaging, especially when you're thinking about a stress myocardial perfusion imaging. Now, with all of this concerns, and well, it seems like the concerns continue to mount, and another one that comes as well, what about the clinical trial data on the calcium role as a gatekeeper approach? Well, in this, I really want to give my kudos to Koen Neiman, who's now the current president of Society of Cardiac CT, who dared to be brave enough to do a study like this, where it was a PROMISE study on a smaller scale. So rather than 8,000 individuals, took 463 individuals and randomized them to a CT and a functional test strategy. But the CT strategy didn't start with a CT angiogram, actually started with the pathway that I'm proposing here, going with the coronary artery calcium score. And if the calcium score is 0, those individuals would not have a CT angiogram unless and until they have a significantly high pretest probability. Of course, those are the ones that it's truly hard to rule out disease. And so almost with this strategy, you can see you can halve the amount of individuals who may need significant downstream advanced testing. Now, but that's really the case. The issue is, can an absence of calcium score rule out disease? And what it is, yet it did rule out disease. And these individuals who didn't have any additional testing in a 2-year follow-up, they didn't need any further testing. They didn't have any adverse outcomes. And this happened in a clinical trial setting. But more importantly, if you recall that the PROMISE trial within the CT strategy and the functional test strategy, there was no difference in outcomes, and especially around the cost. But in this study, almost extending up to 2 years, the cardiac CT strategy resulted in a much lower cumulative event-free survival with a hazard ratio of 0.32. And most of them was because you were able to avoid downstream testing and costs. So take a step back and think about what would happen if the PROMISE would have looked up to Crescent. I think we would have a much different result. If the PROMISE study would have incorporated this pathway this algorithm, it would have led to almost 50% reduction in the need of downstream CT angiograms. The event rate would have been similar or even better, and potentially the CT strategy would have triumphed the functional strategy. And again, looking at the wise words from Kuhn-Niemann, he pointed out, again, excellent negative predictive value. He believes that calcium testing incorporation is justified in the CT algorithm, the pathway that I've highlighted. Of course, you can avoid the contrast medium in about 40% reduction in radiation, which is not a big issue, but the cost and the technical aspects are. But more importantly, this whole notion that coronary artery calcium score is not safe, the rule out with the calcium score of 0 and low to intermediate probability, is really not true. And Kuhn agrees with us. So now moving the thread, of course, now with the advancement of the CT angiogram, we have now an ability to even look at the plaque morphology more than above and beyond just the presence, absence, and obstructive disease. And one of the notions and the concerns comes out, well, we don't want to miss high-risk plaque features. So if you look at the high-risk plaque features, really there are 4 horsemen of apocalypse that have come across. One is truly on the panel A, if you look at the positive remodeling, and panel B, low attenuation plaque, and spotty calcification in C, and napkin sign ring. And one of the key studies in this regard that gave us insights on not only the burden, the prevalence, and the implications with the Scott Hart study. And one of the highlights of the Scott Hart was that if you do not have any of these features, in the next 2 to 3 years, the negative predictive value of that absence of those features, ruling out an adverse event, was as good as 99%. Now again, beautiful pictures, great results, but what about simple results like an absence of a calcium score and having the power of 0? Would that have the same features? Actually, a calcium score of 0 provided the same results with a 99% negative predictive value. In fact, when you take into account, and as you know, most of these features, having any plaque and calcium score as a surrogate for that, and presence of obstructive disease and risk factors, there's so much overlap in all of this. And yes, in looking in isolation, all of them predict events. What about if you put all of them together? In the end, truly it's the burden. And with very simple coronary artery calcium scores that stands the test of time. That's the only one thing that ended up predicting when you take all of these things in account. And of course, some folks have argued that calcium score of 0 may miss some of these plaque features. Yes, that's true. Upcoming results from Scott Hart may suggest about 2% miss, and it also suggests that about 10% of individuals who had downstream events had a calcium score of 0. But you have to take that into the context that about 7 to 8% of individuals even with a normal CTA had an event. So in the end, the benefit is about 1.5% at the most. The question is that worth scanning about 50 individuals more to find one case? That's something, of course, that needs more discussion. But when you talk to the 3 of the smartest people I've known, past presidents of SCCT, Leslie Shaw, Jim Min, and my dear colleague Ron Blankstein, in their accompanying editorial, they came up with a very pragmatic suggestion and saying, look, this group with a calcium score of 0 is a very important subgroup. It's a very low risk. Less than 1% event risk at 5 years. Less than 1%. And only 2% have adverse plaque finding. And then again, they think that the results, especially the favorable prognosis, definitely supports the role of a calcium scaling alone as a mean, as a gatekeeper for selective use of downstream testing such as CT angiogram. Especially in patients, if you're talking about the low pretest risk scores, definitely those coming out with a severe, typical anginal, unstable pain and with very high pretest probability, the calcium gatekeeper is not for them. Now, moving from this whole trajectory coming from about patients with stable chest pain to acute chest pain, this is where I get the biggest pushback and say, absolutely not. Let's just hold it there. There's no way that we're going to think about doing a calcium test and be reassured with a calcium score of 0. So again, what I'm going to do is just dig a little deeper into the data and let the data speak for itself. For example, one of the best study in this regard is the combination of ROMI-CAT, which was done to identify in the ED settings with CT angiogram patients coming with chest pain as compared to standard of care. That combined with the Akron trial, which was a parallel study done almost on similar design. So in this in this paper, Dan Bittner, working with my dear friend Maras Faranek and Udo Hoffman, they combined the data, about 1,200 individuals who had calcium testing as well as the CT in both studies. As I said, in the ED setting, because you're dealing with an even lower risk individuals who are presenting with acute chest pain, actually the prevalence of calcium score of 0 is even higher. About 2/3 of those individuals have no detectable atherosclerosis. And yes, about 4 of these individuals had an ACS, with 1 to 2 of them with anomalous coronary arteries, and then rule out, and then only about 0.5% individuals had an event with a confidence interval of 0.1 to 1.3. The sensitivity, as we have seen in the stable chest pain, about 95%, but more importantly, a 99.5% negative predictive value. So now, talking to my colleagues in cardiology and primary care, hospitalists, and ED settings, so what's generally being considered? As we truly know, there is no such thing as a 0 risk. Of course, we're looking from a legal, clinical, and mostly from a patient's perspective, how safely we can discharge. And if you look at the CTPE protocol, usually a 1% miss rate at the most is considered a pretty safe threshold. And as what the study authors found, that although, yes, the upper limit of the 95 confidence interval was included that threshold, which is accepted as minimum for safe discharge. So we're not too sure, because it went from 0.1 to 1.3, and that was really a function of the low power. And in the end, despite this powerful data, we couldn't come up with some stronger recommendation to emphasize the incorporation of the calcium testing in our diagnostic algorithmic pathway. And the whole idea was that you should just proceed with the CTA without calcium scoring. But if the issue is about this threshold of 1%, then I would refer to a fantastic meta-analysis eventually led by John Mamarin, Suman Cheng, Faisal Nabi at our group, that without even including this study that had about 1,200 patients, look at all the trials and the studies and found about 3,400 individuals who were presenting with ACS and had undergone a calcium testing. Again, 62% had a calcium score of 0. The MACE event rate was almost similar to what you saw in the Akron study, upon 0.61, but with a confidence interval about 0.51% to 0.71. Again, reassuring the ED physicians that with a very high sensitivity and negative predictive value, you can safely discharge patient in the right group with the low to intermediate retest probability with a calcium score of 0. And not only that, but even in the real world, Brian Shajara and Udo Hoffman looking at the Mass Journal real world evidence, and they found out that a calcium score of 0 among patients getting CT angiograms for acute chest pain, you can rule out just with the calcium score of 0 with a 99.5%, and you can actually rule ACS out with 100%, even if you incorporate the TIMI score. Again, suggesting in a real world setting, the identification of calcium, in addition to risk factors, provides an excellent negative predictive value to identify those at low risk for obstructive disease. What else do we need? And that's kind of the rationale when I brought up this conversation in one of our discussions at one of the national meetings, and I suggested that I clearly see a value of calcium score of 0, as I've shown you, as a gatekeeper for more advanced testing, so that we can add value in managing the majority of the low-risk patients with acute chest pain without the need of any further downstream testing, reduced the length of the stay, not only the patient but also the societal cost. I again got the pushback that this whole notion that somehow a calcium score of 0 alone is not safe. And yeah, we are talking about an overall rate of obstructive disease to be very low, but it's not 0. And we're speaking about safe discharge of patients after a calcium score of 0. And in spite of this data, the perception is that it's not enough. And point blankly, at one of the other conferences, I was blankly asked that, how do you sleep? And how would you sleep if you send somebody home with an acute chest pain with low to intermediate risk score and has a calcium score of 0? Well, valid points. But again, taking this criticism, we went back to the board and also looked at a large database. And this is a study led by one of our star fellow, Gautam Gandhi, who's working with our group, who's a resident at MedStar in Baltimore, where we took about 6,000 individuals who underwent CT angiogram for acute chest pain at Baptist Health, South Florida. And then again, 1 in 2 of these individuals had a calcium score of 0. Yeah, there were about 4.5% who had minimal atherosclerosis, but less than 100 had obstructive disease. And less than 1 in 200 actually had ACS or underwent revascularization. So if you look at the negative predictive value was about 99.3%. And when you compare that with established modalities, which are class 1, class 2A recommendations such as stress echo and stress SPECT myocardial and even CTA, the stress echo negative predictive value is 96% to 95% for SPECT myocardial perfusion, which are extremely acceptable. But when you put in that context, definitely a negative calcium score of 0 provides you more value. So my whole notion, which I'm still unable to get, that the risk of having an acute event or missing an obstructive disease with a calcium score of 0 is lower than a normal nuclear stress myocardial perfusion imaging test, or even a stress echo, which is routinely employed in a majority of the hospitals in the country. So why are we unable to accept the power of 0 in these individuals? Now, just for humor purposes, think about if other modalities had the same diagnostic prognostic performances, my colleagues, and I just joke around, would be jumping up and high with joy. And I'm an avid follower on Twitter, would be seeing all these things trending, just as for CMR and nuclear all clear and stress echo every day. Now, this is just for fun, but again, I think that our CT community has not truly embraced the power of a calcium score of 0, where almost half of these individuals can usually add the value of reducing the downstream event and also expanding the scope, where in places where the CT angiograms and myocardial perfusion imagings and advanced imagings are not available, that it can be utilized. But again, this is the context of tests that are happening and you're comparing different studies. And now, as I said about the red and the blue pill, and even if you're not convinced, and I say, what about, I tell you, there is a study that was done in 1,000 patients, low risk, acute chest pain, who had negative troponins and negative EKG. And I offer you the blue pill. And the blue pill is, that test is gonna be normal in 91%. And let's assume in the next 6 months, about 1.2% individuals would have some MACE. On the other hand, you have the test B, which is going to be normal in about 65%, and the MACE rate is going to be 0.3%. Let's assume both tests are the same cost, same equipment, same utility, same time, same expertise, just to balance. Which pill would you choose? Especially, when will you be more comfortable sending that patient back home? I think so. You will be with the calcium, with the test B. Now, this is a study, a classic study led by Faisal Nabi and John Mamarian, way back published in 2010, that truly gave me the inspiration and had me started thinking. 1,000 patients presenting to the ED setting who had a normal EKG, normal troponin, ruled out, ACS ruled out, all of them got the stress myocardial perfusion imaging, a calcium score was added. Less than 1% individuals with a calcium score of 0 had an abnormal SPECT. And almost half of them had a calcium score of 0. And in a follow-up about 7.5 months, with most of the events happening within that early period, with the normal SPECT, the event rate was 1.2%, which is within the normal limit, which is within acceptable safety profile where ED physicians and cardiologists are willing to discharge patients safely home. Now compare that with the calcium score of 0, the event rate was 4-fold higher. So my response to how do I sleep and how would I sleep if I sent somebody home with a calcium score of 0, the answer is 4 times better. So this is the summary. This is really, and this data has been there for the last decade and plus and continue to reassure. You can rule out with a calcium score of 0 in chest pain patients where 50% of them would have even an intermediate risk, either in acute or stable setting, with a negative predictive value of 97 to 99%. Your short-term events in the real world is about in 2 years there are 0 events. There are 0 events in the real randomized clinical trial settings and 0 coronary deaths in 13 years with a 99 to 100% negative predictive value for ACS, better prognosis than the stress myocardial perfusion imaging. We have that data. Not only we have the data, this is a tweet by Ron Blankstein a couple of years back after presenting some of this information. Almost 80% of the audience, us cardiologists agree that calcium score can serve as a gatekeeper. However, in 2021, what is the reality? The reality is that we are not using, there is no incorporation of this pathway in our clinical decision making. And why is that? When we ask our physician community, the cardiologists, and I can give you an example. Last week, a colleague of mine told me about a case of a calcium score of 0 in the ED. The CTA wasn't working for reasons unknown. They wanted to discharge the patient, but the ED physician actually was reassured with a calcium score of 0, getting an ETT, which I've clearly showed has a worse prognosis 4 times higher than a calcium score of 0. And this is really, in my view, related to the implicit bias in our legacy guidelines. If you look at the 2013 and even the updated ESC guidelines, actually calcium testing is not recommended. In our appropriate utilization criteria, it's not even considered in the rating panel. Same with our 2013 and 12 ACC AHA guidelines. So my understanding and my belief is that we can have all the data, we can have all the conviction, unless and until the guidelines accept and we adopt these findings into their pathways, we will not see any change. And I think we have an opportunity, and I think that the upcoming guidelines doesn't have to completely accept, but at least acknowledge the power of 0. And I understand that it's going to be challenging. There are going to be pragmatic issues. But I cannot think of any reason where the guidelines author can hide behind any dogmatic pretense that there is no data. And in fact, we are trying to incorporate as a better pretest probability where you have to exclude people with high pretest probability. And even if you don't want to do it in a typical chest pain, fine, because in the promise, 77% of individuals who are atypical chest pain. If you want to exclude younger patients, that's fine. And elevated troponins, that's fine. And low pretest probability, that's fine. But in the majority of the individuals who will still fit in the middle age, older individuals with atypical chest pain, I think so the pragmatic decision is to proceed with the calcium testing. And if you have the power of 0, you do not need any further testing. And I know that there are going to be operational challenges, but we have revamped the entire healthcare industry during our pandemic. We can do it. And really to pursue and to make it happen, I think so the more emphasis is going to be on value-based and bundle payment, that will truly move us in that direction. Clearly the data is there. And my sincere suggestion to the guidelines authors is, let's move where the puck is going to be in the next 5 years. And I think so it's going to be in the setting of value-based, and let's find better ways of incorporating calcium testing in our advanced imaging testing. So to conclude, if anybody tells you that the calcium scoring and in the chest pain is it dead on arrival, I think that your response should be, and this was written almost 6 years back, and I'm just going to add to this that the calcium scoring testing in patients with chest pain is still alive and kicking. And you don't need much. All you need is truly to have a little courage to accept the power of zero. And I think so we'll find that in a value-based protocols. I think that this data is enough, and I'm very eager looking forward to the next chest pain guidelines, hoping enthusiastically that there will be an upgrade of the calcium testing in the chest pain pathways with at least a 2A level recommendation for stable chest pain, and hopefully for some more interest in focused R&D clinical trials in its value in acute chest pain setting. So thank you so much for all your attention, and we'll take up some more questions from the audience. All right. So are there studies, so few questions, are there studies about the power of calcium score of 0 in the setting of high sensitivity troponin testing? Some data show that a negative troponin has extremely low event rates, I guess. So your point is well taken. I think so that if you look at the chest pain protocols, most of the time we may not need to do anything if your high sensitivity troponin is negative. For example, most of the European countries, there is no downstream testing. If you have a negative troponin, especially the high sensitivity, I think the patients can be safely discharged, and they can be followed up in an outpatient setting. However, in US and in other places where there is any discussion around having more advanced testing, I think a calcium score of 0 can definitely help further refine the needs for those who may need downstream. For example, a non-contrast a contrast CT angiogram or a stress myocardial perfusion imaging. All right. In practice, how can we deal with a calcium score of 0 and the possibility of a non-atherocoronary cause of chest pain? Example, a myocardial bridge or a congenital coronary artery anomaly. Are these data available about these type of scenarios? So again, the guidelines are there really to prescribe and help us understand for most of the most common scenarios. Definitely myocardial bridging and congenital coronary artery anomaly are a concern. For example, in the Akron and the ROMI-CAT trial, actually there was one patient who had a coronary artery anomaly with the RCA rising from the PA. Yes, those are the possibilities, but in most of the scenarios, and you won't be finding those insights from the functional testing. So in either ways, if that's the risk is more high, or your suspicion of myocardial bridging or a congenital coronary and artery anomaly is high, I think so you should pursue with the CT angiogram. The main thing we have to understand that our nothing trumps our clinical judgment. But if we're trying to go for a triple rule out approach, and I remember having a conversation with Stephen Achenbach and said, there's no such thing as a triple rule out. Are you thinking about an ACS? Are you thinking about a PE? Are you thinking about an aortic dissection? So I think that within those circumstances, if your suspicion is high on the myocardial bridging as well as a coronary anomaly, I think you should also forego functional testing and consider moving ahead with more coronary CT angiogram. How do you think this applies to a patient with a calcium score of 0 but with a COVID infection? Now that's a great question. So COVID infection, as you know, it's a different animal. We are learning almost on a daily basis. So let's divide them in two categories. One is if somebody with a COVID infection is coming with an acute chest pain, and especially in the setting of they might have some ischemic EKG changes, also may have some troponin leak. Prior studies have shown that they may have NSTEMI and STEMI even in an absence of a culprit lesion because of the high prothrombotic risk. So I would definitely have a very low threshold of more further testing and evaluation. But mind you, if it's more of a thrombotic disease, the chances of any ischemia on advanced imaging or on having any significant plaque on a CT angiogram is going to be low. Again, it's hard. My whole notion is that we haven't even yet incorporated calcium testing in the lowest risk patients, one step at a time. Let's get the guidelines, authors, and ACC and AHA to at least acknowledge. Let's get them into our basic protocols. And then at some point, hopefully in the next couple of years, we'll have more insights on its value within the COVID population. And as the result trickle in, we'll definitely keep you updated. Now, do you think that we should take the heart rate into consideration, as higher heart rates may result in missed minor calcifications and they are wrongfully considered at zero? In our experience, at least what we have seen is that unless and until, of course, it's hard for me to tell about when if you're in AFib with rapid ventricle rate, but as long as the heart rates are not terribly chaotic, they are pretty at the basic studies that have looked at the validity of rule out calcium scores are pretty, I would say, robust. However, of course, if you truly want to improve your ability to pick the minimal calcifications, there are two things that I strongly recommend. One is having more thinner slices, and even considering the sub-threshold calcium scores, because there are times where you will see the calcifications, but it will be below the threshold levels, to consider them as a calcium score of zero. So anytime you can move on to the thinner slices in the ED setting, I would advocate using much thinner slices than the traditional 3 millimeters, and also making sure that we are picking up the low threshold calcifications. All right, so for example, what is your viewpoint on calcium testing to select patients who may benefit in calcium score only testing? That's a great question. Honestly, I don't have an answer. If you look at our selection methodology, that's truly based on the pretest probabilities, which takes into account 3 things: your age, your sex, your symptoms. Some studies, for example, from Rohan Khera at Yale, recently using ML methodology, identified that non-pretest probability findings can be incorporated to identify who may benefit from a CTA and a perfusion study. But the heterogeneity is huge. Even in a population that has 77% with atypical chest pain and a pretest probability as high as 55 to 60%, you can see that the disease burden is very low. Consistently, what we have seen is in the real world, be it confirmed, in the PROMISE study, about 50 to 60% of stable patients, chest pain patients, have a calcium score of 0. About 2/3 of individuals in the acute chest pain setting has a calcium score of 0. My threshold for utilizing, and again, unfortunately, we haven't done it clinically. I continue to advocate, as you know, it's not part of, I would say, the clinical practice guidelines. But if I had to do it, I would start with a pretest probability, and anyone with the pretest probability, higher pretest probability, with unstable angina, with a much younger age, at least we can exclude them from a calcium testing right now. But anybody in that middle age, elderly age, low to intermediate pretest probability, atypical chest pain, I can guarantee you 1 in 2 of those will have a calcium score of 0. And as the data has suggested, all over again, and again, that's not my opinion alone. Almost all the experts in this field agree that it can be used as an effective gatekeeper, and you may not need any downstream testing for that. Are there any groups of patients in whom the calcium is less reliable? For example, after chest radiotherapy. Again, this is beyond the scope of what the data we have. Again, chest radiotherapies, the chances are what we have seen in our experience after a prolonged chest radiotherapy and many years after that, the likelihood of having coronary atherosclerosis is much higher, as you didn't have. Now, is that a part and process of radiation injury atherosclerosis? It's hard to know. But as you know, in the chest pain, what we're trying to do is not diagnose with calcium testing. What we're trying to do is, can we safely rule out significant disease and identify a group of patients who's going to have a favorable prognosis with the almost non-existent risk of an ACS in the short-term period and a very favorable risk of not having a CVD or CVD-related outcomes, among whom we can safely discharge and not consider some of these advanced downstream testing. I think so that's where the value is. And that's where most of the data has come around. And I think so in the chest radiotherapy patient may not be the best option. Let's see if there is any other questions. I think so we finished up in time. I truly enjoyed having this conversation and discussion with all of you. As you know, this is a highly debatable, controversial topic, but that's the whole gist, and the whole notion of these conversations is to bring in, open the discourse, and more importantly, have this aspiration and how we can all come together to do better. I think we truly have an opportunity in our cardiology as well as the imaging community in this whole multimodality fashion. And I can tell you that my heroes and people that I've learned the most in this are folks who have been leading these efforts, most of the science coming from Houston Methodist, John Memarin, Faisal Nabi, Suman Cheng. I truly believe that the future is in this multimodality approach, in deciding in a stepwise, especially when you're thinking about value-based medicine and where we can avoid unnecessary downstream testing and costs. So I truly believe in the power of zero. As I said, all you need is some courage to accept it. And I'm hoping in the next few months when the guidelines will come, they will enthusiastically accept the power of zero. Thank you so much.